So first of all, thank you very much. I would like to begin with thank you very much for the organization for inviting us to sharing our humble experience with spine cervical whiplash and elderly valgus. But again, very important, the multidisciplinary team. That's something that we said before. How we did, continuing with the presentation, how did we get here? Actually, we are here because we are risky taking hominids. So in our evolution from the apes and from the other hominids, we took the upright position, and the quickest part in our body is actually probably the cervical spine and the craniocervical junction. As an example of our risk-taking things, this is an example of one of our patients. Actually, she's Swedish, and she was doing skiing. She was almost professional. This is one of our patients. She had a couple of lists of this kind of cervical injuries, and in that case, it's also the helmet weight. So that's something important in the cervical thing. And actually, she had translational BA. After we'll explain later. So about 5. So it means that there was an instability, clear instability. She's only 19 years old. He has unbearable pain, brain fog. And after surgery, it was fused, a long fusion. In this case, she is without pain. Actually, she's taking 1 paracetamol per month, so it's quite normal. That's one of the important things about the outcome that I will explain later. How about symptomatology? Symptomatology is really one of the issues when we present some cases, because sometimes it is not clear. So let me show you an example that the majority of people here in this room, an example of a patient of 45 years female with constant breathing problems, exacerbated by gravity changes and acceleration, pain in neck, back of the head and behind the eyes, swallowing and speaking problems, and facial paresis and hemiparesis. This is the example that probably everybody knows. So this is a patient, a Swedish patient. Here you can see the facial tics. Then here you will see the hemiparesis. You cannot hear the voice because she's speaking, but it's allowed to speak. Okay? Clear hemiparesis, the tics, the facial abnormal dyskinesias. This was done actually, I think it was this was the exploration before the surgery here in Sweden, before she came to Barcelona. There was an spontaneous Babinski, bilateral. So the symptoms are really weird. And then after surgery, 15 days after surgery, this is in our hospital, is the same person, actually. Walking without hemiparesis, without tics, smiling, breathing, speaking. So it's quite spectacular, this case. For instance, we have other cases we'll show you. But what I mean is that at the very beginning, when you see these patients with weird symptoms, doctors tend to think that they are psychiatric. This is one of the important things that we have to avoid. So how about the patient profile? The patient profile in general, with all these kind of patients, are young female in general, with a traumatic cervical injury, or maybe not, because we have the EDS we'll take later. Sometimes weird symptomatology, as I explained before. They are not understood. They are taking rounds and rounds of consultations with several types of doctors. The majority of times, I would say the 100% are labeled as psychiatric. This is 100% almost, because also they show up with other symptoms that seems not to be related to the cervical affectation, like nausea, dysphagia, tightness, shortness of breath, sleep apnea, palpitations, facial pain, syncope. So all these kind of symptoms that seems not related to this. So I would say that in general, the symptomatology, the most important is the headache is quite typical. You may know that the headache is typical behind the eyes and the temples. They explain commonly that they can't hold the head. So actually they say that it's too weight, so they can hold. I remember always a patient that when I said to her to be flat on the stretch, so she was holding the head because it was unable to hold the head. The neck pain is very typical. The brain fog is one of the issues important because the majority of patients do quit from jobs, or they quit from studying at the universities or the colleges, so because they cannot follow anymore any cognitive issues. Tremors, quite common, breathing problems, hemiparesis, quite common also, and even pleasures we'll show later. Heart rate abnormalities. This is one of the questionnaires that we follow, the Brainstem Disability Index. It was published by Dr. Henderson, a neurosurgeon in the US, and we follow the symptoms that can be referable to the brainstem affectation. And these are the most common, I would say: choking in food, walking, vertigo, memory loss, double vision, so swallowing. This is related also to with the position of the neck. What's the mechanism? Before coming here and explaining to some doctors here, what is published so far is that it's probably related to the stretching and to stretching to the neurons. So as far as there is the deformity of stress up to 0.2, it seems that the neurons doesn't work so properly. So, and actually what we see is that the CXA below 130 and probably 140, they begin to not do a malfunction. So the basic mechanisms of the craniocervical junction, biomechanics, sorry. So in general, then, so it's really difficult and complicated to know exactly the biomechanics of the craniocervical junctions. But in general terms, to have an idea, I would say, and I will explain to the patients, that 50% of the flexion extension is located between C0 and C2. That's general numbers. And then the rotation, 50% is located between C0 and C2. The rotation is mainly done by C1 and C2, and the flexion extension is shared approximately. So, but we don't have to forget that also below C2 there is movement. So actually all the neck works as a fold. So we have to consider all the biomechanics. This is important because of the diagnostic. So importantly, why should we consider Ehlers-Danlos? So Professor Smith talks to us about the importance of Ehlers-Danlos and why do we consider it? So because actually, if we consider the normal standard bell curve, so the normal standard curve of the population, and we consider this as the laxity of our connective tissue. So let's say that the Ehlers-Danlos syndrome, which is approximately 0.5% of the population. It can be up to 2%. Here are the papers. It means that they are in that area. So it means that a minor injury here in their spine, a minor, really minor, or even no injury in the spine, it can affect their craniocervical junction or the instability. But also, all these people that are not so hypermobile, but that are in an area where, let's say, a whiplash, a small or not a really serious whiplash, can affect them because of the laxity of the connective tissue. And at the end, it seems that all the joints do not work properly. So EDS can be considered as an example of how that it doesn't work properly, the joints. And actually, one of the things that we see is that whiplash can be considered a trigger of the symptomatology, because sometimes we see patients that they are behaving normally, and then they have a whiplash, and then they begin to develop the symptoms, and then they discover that they are hypermobile. That's one of the typical things. And in the other way around, so there are people that are not hypermobile, and if the amount of the severity of the injury, so if they are here and the amount of injury is big enough, then they develop. We sometimes see people, especially those people with EDS, that without any whiplash they develop, because it's so soft, they are so soft that they develop the symptoms. So symptoms. This is specialized in EDS symptoms, but it's important to remember, because sometimes you can see patients in that 1% of population. Actually, there are 50,000 per million, more or less, so there are quite a lot of people that can have whiplash and symptoms of EDS. So you have to think that these weird things, symptoms can be together. So like refreshing sleep, chronic arthralgias, chronic back pain, myalgias, gastritis, abdominal pain, constipation, tachycardia. So all those symptoms that seems not to be related, but I think that it's important to remember that they are there and they can be possible to be concurrent with the whiplash diagnostic. Also important for us in the clinic is to remember that the EDS or the hypermobility in general, they have three clear phases, but not always also clear in terms of timing. The first phase is the hypermobility, and the hypermobility, the typical case is the gymnastics female that is contortionism, has contortionism. That's the most the best example. The second phase is mainly they don't have pain at that stage. The second stage is pain. They have pain because of the hypermobility, and the last stage is when they have pain and rigidity. So the rigidity is a mechanism of not being hypermobile and not having pain. In this phase, when they are in this phase is when diagnostic is more difficult because the movement, the excess of movement is difficult to be seen. Sometimes we see, so normally this phase is below the 20s, this phase is below the 30s, and this phase is below the 40s, but sometimes in really severe EDS patients we see this phase in the 20s or below. So it means that it depends on the laxity of the ligaments. Here is an example of the difficult diagnostic in a rigidity patient. She was only 18 years old. She was a champion in Taekwondo when she was 14 years, so she was really an active person. She was 3 years from the 14th since 17 years old. She was bedbound with a left hemiplegia, and here the difficulty was that even with upright MRI, it was difficult to read the translation, so the BAI. So it was difficult to see the excess of movement because of the rigidity. Actually, we did some of the extra tests, and she was fused, and I wanted to show you how she is behaving before the surgery. Remember, she was hemiplegic. She is recovering the strength also. She's not hemiplegic anymore. She's recovering the strength in there because she has also tethered core, by the way. And she has a normal life. For her is more than expected because she was bedbound. She has been fused, obviously. So, what are the potentials, spine affectations of cervical spine affectation of the whiplash? This is something that probably Dr. Oliver told you before. I would say that craniocervical instability, it came before what is craniocervical instability. This is something under debate. For us, we understand craniocervical instability in terms of C0, C1 instability. There is also atlantoaxial instability, so it means C1, C2 for us. And then below C2, we call it subaxial instability, so instability in the rest below in the rest of the spine. There can be also these herniations that are also common. Important diagnostic tools, because at the end we have to diagnose and to make sure that the proposal of the surgery that we're going to give to the patient is quite correct. So the diagnostic tools, in our opinion, the most important one is a bright MRI, thanks to Dr. Smith, because he is, as Dr. Oliver said before, he's alone. Our bright MRI is a diagnostic tool for C0, C1 for sure. And with regards to C0, C2, we think still that it's upright MRI, especially in the rotational views, and actually because C1 and C2 is mainly rotating. And also sometimes we need CT scan, a bone CT scan 3D, because we need to see clearly the subluxation. Below C2 and C3 up to C7, we think that the diagnostic can be done with upright MRI. We'll show you later some pictures, and also with senior radiology or DMX. It depends on the terminology, but at the end is the same. So it's a means of testing the movement of the cervical spine. So about C0, C1, so this is the big issue. How to diagnose if the C0, C1 is affected. Why? Because at the end, the flexion, approximately 25% of flexor extension is located here. So if we diagnose that there is an issue here, there is an instability here, we'll tell the patient that 25% of this movement will be lost. And this is something disabling. So this is something we have to consider. Actually, we follow the clinical and neuroimaging international criteria for diagnosis of craniocervical instability and atlantoaxial instability. This is a consensus statement in the States. It was done some years ago. And we're following their rules, let's say. I would say the recommendations for diagnosing it. In any case, we use, it has been told before, we use the CX8, which is very important. we use the grab, the BDI. Also, we consider tonsils, basilar impression, and the BAI is also important. But at the end, it is a question of considering not alone one measure. It's considering all the picture, because these cases are really complicated. It's difficult to isolate. In any case, we try to objectivize the instability at C0, C1, mainly with all these things, and especially with the translational BAI. It means the translational between the cranium and the dents. So we consider normal. Normal is considered to be less than 1 millimeter, and then when we are around 3, 4, 5, it should be considered pathological. What is difficult really is in the stiffness EDS phase, because they are so stiff that they are not able even to do any flex or extension. And then, and other patients that have really pain in their neck, there is a low range of movement. So it's difficult for us to objectivize that there is an excess of movement there. So regarding again the C0, C1, upright MRI, so here there are the angles that we consider pathologicals, the grab, the translational. The BDI is sometimes interesting, I will explain you later. And sometimes we have to take a look to the cranial settings, because sometimes there are not standard cases. I will show you some pictures, it will be easier. So here, for instance, we have a picture of a young girl, 18 years old, with a CXA of 127, and with a flexion grab of more than almost 10 millimeters, which is absolutely pathological. It was said before, there was a question with regards to the tonsils. This girl was operated before, so it was not novel when she came to us. And in this case, there was a residual C1R, so we did posterior laminectomy. And answering the question with regard to the tonsils, we have to take care before deciding to do a posterior forcible decompression and a duroplasty, because especially EDS patients, they have a really fragile dura. So we have to consider at the end how crowded is the craniocervical junction. So it needs to be liquid, CSF liquid, all around. If it's not there, so we need to open the spaces. And also we should consider the quantity of panels, because the panels with the immobilization probably will be going back. So this is another example of another patient with this translational BAI. So we consider this is inflection, neutral, and extension. So we see the differences, and that's one of the ways to see, again, with all the other measurements, and with the clinical, which is very important to consider, to see if there is movement, excessive movement or not. Another example, talking about the BDI. Sometimes we use the EBDI when it's not evident. For instance, in this case, this is an American patient, EDS, by the way, who had a whiplash. And in this case, in the neutral position, the BDI was 3.5 more or less, and in the extension is, here you see the image, in the extension it was almost 8.5, so it was an increase of more than 65%. So it means that there was the ligaments did not support the head. So the symptoms obviously were crank-brain. She has all the things, but this is just an example of how things can be done. Cranial settling. So sometimes what happens that we do not see real changes. So the cranial setting was described with the rheumatoid arthritis some time ago, and then this experience had been applied to the whiplash people and to the patients and to the instability patients. So BDI can be up to 12 millimeters, and actually said the cranial settling to be the significant changes in the BDI between the supine position and versus upright position. So when you are supine, there is no weight of the head, and then it should be bigger than when you're way upright, and then all the weight of the head makes it shorter. But normally normal people do maintain that BDI, but in let's say in people who has all the ligaments are softer, or maybe because of their damage, then the BDI is lower. So there is a change. Well, that's another topic, difficult to explain. Actually, I put here C1, C2, the vertical translocation C1, C2. Actually, it can be in C0, C1, C1, C2. But in any case, so we said that normally these locations, so the subluxation is in between C1 and C2. But sometimes it happens that the translocation of the dens is upwards. So we have a movement upwards. This is called sometimes as superior odontoid migration, and the maximum expression can be considered this discussion, the basilar invagination or the basilar impression. So examples, these are some of the papers that have been published about that. Again, the rheumatoid arthritis has been because of the number of patients it has been where it has been more studied. Also in clipper failed patients, it has been the superior odontoid migration, sleep apnea. Actually, normally we have to consider that below the McGregor's line we have to have all the dents below. If it's upward, then some problems come out. So as a general concept, when you have an upward translocation of of the complex C1, C2, what it happens is there is a lateral mass collapse of C1, and that it's embedded in the cranium. So it's and actually I will show you one case. And then there is an ascent of the odontoid peg. It's very important to note that the ADI, so this distance here, can be normal or even decreased because it's fixed, that area. And that's one of the measurements that we do, the Redmond journals. There are some in order to know if it's upward translocation or not. Importantly, with this kind of patients is they are having difficult to diagnoses like dysphagia, dyspnea, heart rates, disturbances, and other things. Like for instance, this is a case of a cervical translocation, and actually, as you can see, so the medical literature says that it needs to be above this line. More than 3 millimeters is considered to be basilar impression. It was less than 3 millimeters, but you can see here there is no BDI, so it's an upward translocation. She has a kind of clip of fail here. Okay, you see, and this actually, the important thing of the surgery is that we can confirm the diagnosis intraoperatively. So what we saw, Dr. Oliver, remember in that case it was absolutely embedded, the C1, C2, C1 especially was absolutely embedded in the C0. So there was, but it was moving a lot, quite a lot, all the rest of C2, C3 and the rest of the subaxial spine. This was a young female, and the clinic was dysphagia, dyspnea, difficult to swallow in, hemiparesis, and a paraplegic because she has a tether cord. Another case, similar. So the last case was, let's say, the last stage of this vertical translocation, and this is an early stage case of vertical translocation. This is a male, 50 years old, by the way, Swedish. And amongst other symptoms, tachycardia, dyspnea, no sleep at night, and especially with bumping activities. So at the end, it seems that the movement of the odontoid peg is doing some damage around here. The BDI is really small. So atlantoaxial instability. So it seems to be the movement between C1 and C2. Here, the upright MRI is really the most useful test. So here you have the instability. Professor Smith explained before. We sometimes use the CT scan because it gives us also good images and sometimes let's say the reassurance that we are making it do well. So here in this case it was more than one centimeter. It's considered normal up to 8 millimeters, no more than this. Other images like this, do you see here? It was here, I don't know, I think it's around 10 also. Other images like this, you see it? Here, other images here, actually all the joint of C1 is out, you see? And here we can even guess that it was the C0, C1 was out of place. But it's just a guess. So it's difficult, the C0, C1 is really difficult. Subaxial instability. So we have to consider the spine as a full. So if we have an injury in the cervical spine, it will affect for sure the C0, C1, C2, but also the other part of the spine, like below C2, because the injury affects all the spine. So below C2 up to C7, we still think that upright MRI give us a lot of information. Like in this case, we have a CXA of 130, but also we have here some damaged discs, and with the feeling that there is some instability out there, especially, and there is also compression, inflection of the spinal cord, which gives some symptoms to the patients. And here we have another case similar, so let's say a pathological angle, and also it seems there is some kind of instability here. But for instance, in this case, we suspect only a couple of discs, but in this case, with the senior radiology, this is a senior radiology, and then you can see that there are more instability, so below C6 in this case. So that's one of the tests that we do to make sure again that we are proposing the patient the right thing. Because at the end it's different to propose a short fusion between C0 to C2 or proposing C0 to C5 to C6 fusion. It's absolutely different because the loss of movement, it will be important. But it's important to know it, because if you only fuse, this is something that I will explain you later, if you only fuse here, then you can have problems later in the lower spine. About surgery, Dr. Oliveira explained it very well. I will not going through very deeply, but we have to remember always that surgery is the last option. The last option. So it's only an option when everything failed. That's important even for us. So we have to consider it. So what do we do in one hospital? We review all the MRI, all the neuroimaging. The majority of patients do contact online, so we send them all the Osgood Street, BSA, and a full questionnaire to know all the symptoms. And we do the clinical correlation between the MRI and the symptoms. And at the end, obviously, we have a clinical review personal. We do the CT scan for the neuronavigations with the CNS slices. Sometimes, it depends on the case, we do a 3D CT scan with head rotation. Senior radiology, if it's necessary, we do not see it. If it's not necessary, we don't do it. And then at the end, we try to confirm the diagnosis in 3 steps. So if there is instability in C0, C1, in C1, C2, and subaxial instability. We do the neuronavigation preparative planning to plan how to put the screws and there is any anomaly. And very important in this kind of patients, so we have to rule out all the potential comorbidities, because at the end, the patient is a full thing. We have to take to the full picture, and they have many times spots, abnormalities, cardiac abnormalities, and other things, especially in the EVS. So these are examples of the preoperative planning. Here in this case is what Dr. Olivier said about high riding vertebral artery. So it was not possible here to put on a screw. This is important to know. Here, for instance, let's say the amount of bone in the occipital is not so good, so we have to plan alternatives in those cases. This is the software of the preoperative planning. So we're planning here all the screws where they have to be placed if this is not room, if not. So this is technical, but I wanted to show it to you. So we use the Hello Best, as Dr. Rodi said, again, to check, because sometimes the diagnostic is not really clear. I mean, it's clear, but we need diagnosis. We need to confirm it. And sometimes what we do is an ex juvantibus, let's say, diagnostic with the halo. So we, and because we need to check the confirm the diagnosis, and second, to position the patient in the right way. For instance, in this case, it was very difficult to position the patient if the patient was asleep, because it has dysphagia and abnormalities in the position related to the position of the neck. So we have to do it with the patient awake in order to know if it works. And now in that position, we take the patient to the OR and then we operate it without touching. So we confirm the good positioning before. In other cases like this is a special case. In other cases like this, there was not possible diagnosis. It means because this patient was having 40 seizures per day. So you will see what happened even in this. So this is the patient who had sorry, there is no. But actually, I was holding it. This is me. I was holding the head because as soon as we tried to do the radiology, it happened that she has seizures. So what we did is to put her on a halo, and she was out of without seizures for more than 3 days. So it means that actually the traction worked, and the reason was somewhere there, because it was the diagnostic was not by MRI, but it was done by the halo. Let's say is one way of treating things. Actually, I will show you later. She is without seizures. So this is the intraoperative planning. We spent quite a lot of time measuring. This is something that the doctor will explain also. Measuring the things, measuring what the angles should be to put in the correct position. Again, it's very important for the patient to be with a normal gaze, not looking upward, not looking downwards. And also, we have to think of the lower doses. Sometimes it can be, sometimes not, but we spend quite a lot of time doing this. This is an example just after the operation with the nice low doses and with all the screws, okay? And then, very important for us is anesthesiology team, because especially with the ADS patients, they are not so stable during surgery. So they have heart abnormalities, blood vessels abnormalities, so are not so stable. So, and also intubation, especially with this, when you have a craniocervical instability, you have to be very careful when you are intubating the patient, because it's a dangerous thing for them. So the majority of times is done with a fibroscope. Here the doctor Kimia is doing all the neuromonitoring. So neuromonitoring, I will not repeat, so it's very important for us to control that everything is under control during surgery. Here are some intraoperative pictures, so with the setup, so this is before the surgery, we are planning here, this is the patient, here is the setup with the final positioning of the head of the patient. Okay, all the setup here with Dr. and me, we are doing some measurements of the angles. Here intraoperatively, again, we are always 3 surgeons in these kind of surgeries because it takes quite a lot of time and there is a lot of work to do. Here Dr. Oliver, me and Dr. Bravo doing several steps of the procedure here with the neuronavigation system. Here also the microscope stage, so we have to sometimes to do it under microscope. Here are the results of the surgery, the intraoperative pictures, similar to what you have seen before. See, this is the occiput, this is down to C7 or C6. So we put ribs, which is nice, really nice, because they adapt to the contour of the spine, and we always put wires as extra bone, because at the end the rods and bars are only going to support, but the final fusion is going to be with the bone. This is again another picture. Very important intraoperative findings. So before we do anything, we check. We are the checkers. So we are checking if it moves or not, because the majority of times there is a clear correlation between what we have been diagnosed and what we find out. But sometimes it happens that it's worse. It means that, for instance, the subaxial spine is even worse, and the patient needs an extra level. So we check if everything, what is needed. And it's very important for us to confirm the diagnosis, because we feel more comfortable with the proposal of surgery. A key thing, the postoperative management. The postoperative, because it's not just a question of operating a patient, it's a question of management, all the comorbidities, and at the end the patient survives and has no complications. Especially in the EDS patients, they have quite a lot of comorbidities like the POTS, mast cell activation, can have even angioedema, by the way, gastroparesis, dysautonomia, pain, because they are, as we were talking yesterday with the doctor, the pain is one of the issues. They have a hypersensitivity, and especially they are not responding so well to painkillers. So we have to manage all those things that sometimes give problems. Normally hospital stays around 8 to 12 days. It depends on the patient, more or less. We always recommend to stay in Barcelona for about 10 to 15 days more extra. So, and then we in an apartment or hotel, because we want to see them for those weeks to check that everything is okay. We see them once or twice a week to check that everything is okay. Before we recommend them to fly back to home, because after 12 days they feel good, but it's just a feeling. They are not ready yet to go to have sorry. Oh, Okay, I will speed up the process. And yeah, so 15 days. Issues to consider. 3 minutes? Issues to consider. So, anti-cell level disease. Why? Because, for instance, I would like you to see this. This is a patient operated outside the European Union, okay? So let's say he's in the US, and then this is 6 months. It was operated 6 months ago. So if you see the DMX, you can see there is a subaxial instability below. Do you see it? And below, and even here. So we can repeat it again, but you have to make sure to consider that if you're fusing here, the below, and especially if you leave a segment in between without fusing, you can have problems. That's one of the things to, that's why I said issues to consider. Okay, so here another example again, this young lady was operating in the US, and 2 years after the operation, she developed, I don't have here the same radiography, but she developed a subaxial instability with a lot of symptoms, and now she's fused and she's okay. Another example, actually this is a Swedish patient, this one, by the way, and almost quite the same. So here, weird symptoms, has been to several doctors, several consultations, and actually the problem is that when you fuse, you leave spaces, and especially in EDS patients or hypermobility patients, when you have an excess of movement by natural, then you have to consider these issues. So, okay, I will skip this. The outcome in general is pain improvement. So I said before, patients are around 7 of VSA. They go down to 2 or 3. We have 0 pains in some patients. But normally we'd say 2 or 3, so it's not 0, but it's a big improvement in the quality of life. The neurological symptoms improve. It varies, but there are some dramatic changes. In EDS, there are some comorbidities that you have to address, and they are back to their lives. We have not enough time, but I will to show you an example of the changes of, there is no, there is maybe, yeah, that's, let's see. Okay, you will show, this is a young lady, I will explain you because there is no voice. So you will see the pictures. This is a patient that has been in bed for 3 years. No, I think it's the, yeah. 3 years in bed, the bone crisis, 40 crises per day. She even went to have the bachelor in biology in her stretcher. You will see her here. 3 years bed bound, so no life. And now after the surgery, this is 2 months after the surgery, she is upright. She has no crisis, and she is recovering. Actually, she's recovering the bladder function and also the leg movement. So this is something that really encourages us, and it's really rewarding to us because we help people to get, this is in our hospital, this is the fusion. Okay, this is with the color after the post-operative period, and this is something that encourages us to continue on helping these kind of patients. So wrap up, and that's the last slide. So it's needed a multidisciplinary team. There are a lot of things to consider. The case evaluation is really complex, especially in the CE0, C1. Surgery proposal extent affects the neck mobility and the quality of life of patients, so is this ailing? So there is a price for that. So we have to make sure as much as possible to what we propose is more or less sure. Surgery is complex, and also the postoperative management. This is something that we know. And in general, the outcome is good because of the pain and the neurological signs. And just as last, I wanted to, if it's possible, it's 1 minute. No, sorry, but the problem is the voice. So let's see if it works. No. She was speaking in Swedish, by the way. This was speaking in Swedish. She is one patient. Maybe. No, here. I don't know how. Well, it was a testimonial. I will explain to you. It was in Swedish. Then she was 15 days after the surgery. She had the pain has been released, and she was smiling. This was the one. And the second is Anna Karin. She was explaining that she has been, is labeled as a psychiatric person, and that this affects her a lot. So being labeled as a psychiatric, and she says that she really doesn't feel as a psychiatric. She knew she wasn't psychiatric, and she wanted just to address to you and to all the people to say, hey, there is a solution out there, and I'm not a psychiatric person. It just was a problem with my neck. Okay, so it was that. Thank you very much for your attention.